So very good afternoon friends. If you are able to hear me and also see me, please do write in the comment section. Please do reply in the chat section that you are able to see me. Yes, friends, so today we are going to discuss the connective tissue diseases and the drug reactions. So this is myself, Dr. Maddineni Srinivas, your dermatology educator on Unacademy platform. I have done my MBBS from Siddhartha Medical College, DDVL from JSS Mysore, and secondary DNB in dermatology from Hindu Rao Hospital, Delhi. Yes, this was the actual course on FMGE, which was a short practice course which I have started on September 20th, and it was completed on October 2nd. So there were few small topics which were remaining. So in that yesterday we have already seen dermatitis topic on the YouTube, so you can check that video if you want. So it is there on the YouTube, and today we are going to discuss the connective tissue disease and the drug reactions. So these were some of the testimonies of the students who after writing their August session of FMG gave to me, and you can see they were able to clear the FMG in their first attempt, and they were very happy. So if you wish to join the Unacademy, or if you want to just see how is this platform, just download this app on the Google Play Store, or even in the Apple Store it is available. You can download it. And what are the advantages with this plus subscription of Unacademy? You will get daily live classes instead of boring offline classes. If you feel that live classes are very lively, then you can attend the live classes. They are structured courses, and there will be live tests and quizzes also, which will also be discussed by the educators. There will be unlimited access, and these are all the payment details of the subscription. And if you wish to take the subscription, you can use my referral code DRMSD to get additional discount. And now the Unacademy has combined with the Prep Ladder and it has formed iconic subscription, with the help of which you can also watch the Prep Ladder videos if you are interested in that. Also you can access the question bank also. These are the subscription details for the iconic subscription. The minimum duration is 12 months, and this will be the subscription charges, and you can use the referral code DRMSD here also. And these are free tests, you can attend these tests. So this 8 o'clock session is for NEET PG 2021. There will be 20 MCQs which will be asked from various subjects, and at 9 o'clock the questions are targeting 2022. And so these are the topics which we are going to discuss today: erythema multiforme, fixed drug eruption, SJS/TN, systemic lupus erythematosus, dermatomyositis, and scleroderma. So real quick we are going to discuss these details. Now please, I want everyone to answer this question in the chat section. So please try to attempt this. Even in today's telegram question also I have asked this question. Thank you Roger Jane, thank you Roger John for the clarification. So everyone, please do attempt these questions. Okay, Seth Phil says it is erythema multiforme. LY says it is C, that is erythema multiforme. Okay, Krish Patil says it is dermatitis herpetiformis. So okay. So I hope everyone agrees with the answer erythema multiforme, because that is the answer here. Yes, okay. Krish also says it is C. So Lyle Moh says it is D. Okay, we'll see. So please read the question carefully. So 25-year-old truck driver with repeated herpes infection. So with following skin lesions, so skin lesions are given in the image. What is the diagnosis? So this was a FMGE question. So with the help of these clues, what you should understand is truck driver is a clue that there is a high risk for sexually transmitted diseases, and also in the question itself it is mentioned that the patient has herpes. So if at all the patient has a history of herpes and these type of lesions are there, these are called as target lesions. Yes, very good, Sethville, you are right. So these are the typical target lesions with 3 zones, okay, central zone, the middle zone and the peripheral zone. So we'll see in brief what is the erythema multiforme and its clinical features. So there will be a special lesion which can be seen in this erythema multiforme. They are the target lesions. And this is basically a self-limiting type of cytotoxic dermatitis, okay. And you should remember the causes for erythema multiforme. The most common one, of course, is in most of the patients we cannot find out the cause, so it is idiopathic in most people. But the most common infectious cause for development of erythema multiforme is herpes simplex virus. And after that comes the mycoplasma and after another bacteria, mycobacteria, whatever it is. But please note the most common cause is a viral cause and it is herpes virus. And apart from that, also drugs can cause this EMF, and among the drugs, NSAIDs, antimalarials like hydroxychloroquines and sulfonamides are the ones which are important to be remembered. And even connective tissue disease like systemic lupus erythematosus can also cause erythema multiforme. In even some malignancies like hematological malignancies like leukemias can also cause. So there are 2 types of erythema multiforme. This is not so important for FMG. They are minor and major. In erythema multiforme minor variant, the skin involvement is going to be very, very mild, okay. There will be only few target lesions and mucosa usually will be spared, whereas in erythema multiforme major, which is a severe variety, has mucosal involvement, okay. And the typical target lesion, so this is the target lesion, with 3 zones. The central zone will be dusky and there can be studded, it can be studded with papules, vesicles, bullae. So all these lesions can be there in the central lesion. So here you can see this shiny fluid filled lesion, you can say it is a vesicle. So vesicle is present. So it will be followed by a next zone of edema. So because edema is there, that is there is a fluid collection. So this zone is going to appear white, that is it is going to appear pale when compared to the central and the peripheral most zones, and the rim will be having erythema, that is you can see the central erythema followed by a pale zone followed by again erythematous zone. So now we will see another drug, important drug reaction. It is called as FDE. In short, it is fixed drug eruption. So this is all the drug reactions are basically examples for delayed type of hypersensitivity or type 4 hypersensitivity reactions, because there is a cytotoxic dermatitis involved in this, okay. There will be destruction of the cells. So it is cell mediated immunity that is playing a role. That is the reason why these are examples for type 4 hypersensitivity reaction. And the drugs which are responsible for FDE are also important, and the sites where the lesions are seen is also important. So the drugs like NSAIDs, that is a painkiller, these are going to cause FD lesions over the lips. I will show you the image also. And the cotrimoxazole, this particular, that is, it is also called Septron, it is going to cause FD lesions mainly over the genitals, okay. So there is a time interval between the exposure and the clinical manifestations. So if at all the patient is first time exposed to the drug, it will take a week to 10 days for the lesions to develop, okay. And if there is a re-exposure, that is if for example say a patient has a fixed drug eruption propensity to develop after intake of NSAIDs, he took the NSAIDs for the first time, then after 7 to 10 days the lesions will appear. Whereas if he again takes the same drug, that is there is a re-exposure, then within 30 minutes to 8 hours there will be lesions. And how are the lesions going to be present? They are very well demarcated dusky red blocks with peripheral erythema. So we will see the picture here. So here you are able to see a central dusky red block is there, and the periphery is showing very active border, that is erythema. So this is the characteristic of the lesions of fixed drug eruption. Here you are able to see near the umbilical cord, and here you are able to see over the lips. And there is a very characteristic feature of this fixed drug eruption. So the name itself suggests, so fixed drug eruption. So these are eruptions which are related to drugs. So these are eruptions. So basically the characteristics of the lesions we have seen already in the picture. And the name fixed is given why? Because if the patient takes the medication for the first time, then if for example a patient has over the lips, then again after re-exposure also there will be lesion over the lips, and exact same side the lesion is going to reappear. That is the reason why these are called as fixed drug eruption. And one more characteristic of these drug reactions is that always there will be a hyperpigmentation which will be left behind once the lesion heals. So after this active phase, this is the active phase where you are able to see this erythema. This is the active phase. Once the lesion's activity reduces, then it is going to heal with a hyperpigmentation which will remain, and it is very difficult to treat also. Okay. So in the treatment part, what is the treatment we should give? We should advise the patient to avoid the drug intake again, because if the patient takes it again, there is very high chance that he or she will develop the lesions very quickly, that is within 30 minutes to 8 hours time. And in the active phase, we can give topical steroids, which are basically the anti-inflammatory medications. Okay, and now coming to the SJS and TN. So these both are extreme of the drug reactions, which are also called as severe cutaneous adverse reactions. So severe cutaneous adverse reactions, and as the name itself suggests, so these Stevens-Johnson syndrome and toxic epidermal necrolysis are more than 90% of the times they are drug induced. Okay, there can be even other causes, but for NEET PG entrance level, all you need to remember is that these are mainly caused due to the drugs. And what are the drugs responsible for causing this Stevens-Johnson syndrome? So in case if you are doing your internship, there is a high chance that you might see 1 or 2 cases of SJS or TN if you are from government medical college in your casualty. So these are medical emergencies, okay, dermatological emergencies, Stevens-Johnson syndrome and toxic epidermal necrolysis. So there are few subtle differences, and I will show you the images of these conditions and how they look. So the medications which are responsible are NSAIDs, the painkillers, and antiretroviral therapy, allopurinol, anti-epileptics. And in the anti-epileptics, you should remember this carbamazepine. This was a JIPMER question which was asked, what is the HLA association of carbamazepine and TEN? So it is HLA-B1502, and even sulfonamide. So all these medications can provoke this SJS-TN. So the pathogenesis is that all of them are cause cell-mediated cytotoxicity. So basically they are going to induce granulescence and keratinocyte apoptosis. And because of the activation of Fas ligands and Fas receptors, there will be ultimate cell death, because of which clinically we can see the epidermal detachment. These cells which are going to die are of course keratinocytes. Keratinocytes which are present in the epidermis, so there will be epidermal detachment ultimately. And how do we diagnose it as SJS or TN? Based upon the body surface area which is involved. If at all the body surface area involved is less than 10%, we are going to call it as Stevens-Johnson syndrome. If it is more than 30% of the body surface area involvement, it is called as toxic epidermal necrolysis. And so in the clinical features, so after the drug intake, the patient is going to develop the lesions within 4 to 30 days. And unlike the erythema multiforme and fixed drug eruptions in SJS and TEN, because these are dermatological emergencies, the patient is not only going to get only skin and mucosal lesions, there will also be constitutional symptoms, that is fever, arthritis, myalgia, body ache. So all these will be there. And in the skin, So we have seen in erythema multiforme typical target lesions. So but here in SJS and TN we are going to get atypical targets with only 2 zones. That is the reason why they are called as targetoid lesions. And in erythema multiforme the target lesions are going to be predominantly present over the distal extremities. Whereas in SJS and TN the targetoid lesions are going to be predominantly seen in the proximal limbs and also over the trunk. Okay, so these are few differences between erythema multiforme and SJS and TN lesions. Okay, and in the mucosa and also there is one more characteristic, that skin is going to be very tender to touch, and in the mucosa more than or equal to 2 mucosa will be involved in these SJS and TN. There will be hemorrhagic crust which will be present. I will show you how that will appear, and there will be diffuse erythema over the skin, and sheet like epidermal peeling will be present, which is called as pseudo-Nicolsky sign. And it is called as pseudo-Nicolsky sign instead of Nicolsky sign because in Nicolsky sign it is acantholysis which is the underlying pathology, because of which there will be epidermal blistering and ultimately peeling. But here in SJS and TN the keratinocyte necrosis but not acantholysis is causing this peeling. That is the reason why it is specifically called as pseudo-Nicolsky sign. And this is the clinical picture of you can say toxic epidermal necrolysis. Why I told TEN? Because you can see in the image obviously more than 30% of the body surface area is going to be involved in this particular person. So this image is an example of toxic epidermal necrolysis, and here you are able to see the oral mucosa, that is the lips are showing the hemorrhagic crust, that is the blood has been dried up and it can be seen over the lips. And also there are petechiae purpura lesions which are seen periorally, and you are able to see diffuse erythema and also sheet like epidermal peeling. Sheet like epidermal peeling is also evident in this picture, and you are able to see obviously few vesicles and few bullae also. So this will be the classical picture of SJS and TN, and this is for your reference purpose. So you can see that erythema multiforme and SJS and TN, these are basically a spectrum of disorders with few differences. Okay, in erythema multiforme the main cause will be infectious cause will be herpes, whereas in SJS and TN the main cause are going to be the drugs. And also the mucosal involvement will be very less in erythema multiforme, whereas it is going to be extremely severe in SJS and TN. So this is basically a spectral disorder. So yes, now please try to answer this question in the chat section. So I hope now everyone can answer this. Most common cause of toxic epidermal necrolysis. Yes, very good. I think everyone is with the right answer now. Yes, you are right. It is the drugs. So what will be the treatment of this condition? Obviously, we should stop the offending drug. Stop the offending drug. We should take the proper history of all the medications which the patient took, and if there are any ART, painkillers or anti-epileptics, we should immediately stop them, and we should shift to other medications which are going to treat the patient of the other conditions, but they are not going to provoke this SJS and TN. And we need to treat the patient as if we are treating a burns patient, because all the epidermal peeling is there, so there will be increased risk of all the metabolic derangement, and there will be high risk of a patient to develop infection. So fluid and electrolyte balance, and in the proper management part we can either give steroids or cyclosporin, and even intravenous immunoglobulins can also be used. So this please so this is for Dr. Krish, how I prepare for dermat if not ready yet. So December 2020, so you can download the Unacademy learning app and check out few special classes. Also I am planning to take on dermatology, that will target the FMG. I will post it in the Unacademy Telegram group. There is a Telegram group, you can join that. And those who are, if at all you are targeting NEET PG 2022, so this is a course which is a plus course, and it has been started on November 1st, and we have completed till this point. So these are the classes which are remaining. You can attend these remaining classes if you take a subscription, if your target is NEET PG 2022. Okay, so now please try to answer this question in the chat section, friends. 25-year-old female came with fever and oral ulcers, and she developed erythematous lesions over the face which are shown like this. So what will be your diagnosis? So Shivram Hegde, actually I have discussed this in detail. Please check the video from the beginning. So this mainly I am targeting the FMGE exam, in which so much of depth will not be expected, and it will be mainly important topics which are going to be asked again and again each and every year. And maybe this particular FMG session might be the last also, so we should be prepared for everything. Okay, yes, so many of you have answered it as SLE, malar rash, SLE. Yes, so it is SLE in fact. So we'll see what is this SLE, that is systemic lupus erythematosus. So basically the lupus erythematosus, so the LE is also again a spectrum disorder, just like how we have seen the drug reactions is a spectrum from erythema multiforme to SJS-NT, and so this lupus erythematosus is also a spectrum where on the one side of the spectrum you can see only skin involvement, and it is called as discoid lupus erythematosus. And on the other extreme we are going to have this SLE, which is systemic lupus erythematosus, and the name itself suggests that systems are going to be involved predominantly over skin in this systemic lupus erythematosus. And in between we have subacute cutaneous lupus erythematosus, where skin is the predominantly involved structure, and also other systems can also be involved. So basically what is the lupus erythematosus is there will be multiple systems involved, and there will be autoimmunity. So that is the patient's own antigens are going to have antibodies produced in the body. So these structures are mainly intracellular structures, and that too mainly nuclear. Against the nuclear antigens the antibodies are going to be produced. So in the this discoid lupus erythematosus, basically this is a chronic form of lupus erythematosus where you are going to get discoid plaques over the skin, and that too all the lupus erythematosus, all these diseases are going to have photosensitivity. That is, wherever there will be increased exposure to the sun rays, those are the areas which are going to be preferred, and those are the areas where the skin lesions are going to be seen. So here in DLE, the sites which are going to show the these discoid plaques are scalp and face. So because these are more exposed to the sun rays. And how is a typical lesion going to have? It is going to have 3 zones. In the center there is going to be a depigmented lesion. Depigmentation can be seen in the center, so here you are able to see. And if the disease is active, then we are going to have a central active zone. Central active zone will be there, and here the characteristic findings will be telangiectasias, that is permanent dilatation of the capillaries can be seen, and there will be follicular plugging. And in the third zone there is going to be a hyperpigmentation. So here in this image you are able to see this central part is depigmented, that is it is white, and it is surrounded by this part which is hyperpigmented. Increased pigmentation can be noted down here. So this is a typical skin lesion of DLE. This could be even a future image based question, so you need to be well aware of this. And there is one more sign, not only there is one more sign, carpet tack sign, but even Schuster sign is the other sign which is associated with DLE. So in the concha, if at all there are lesions of the discoid lupus erythematosus. So here you are able to see a central depigmentation is there with surrounding hyperpigmentation, and if you look closer, then you can also observe there is a hair follicle which is dilated, and there will be hair follicular plugging and also can be seen. So this is this particular phenomenon where you are able to see the DLE lesions in the concha. It is called Schuster sign. And one more sign is there, carpet tack sign. So I have told you that in these lesions of DLE, the hair follicle is going to become dilated. So usually if you think this is the skin and these are the hair follicles, small hair follicles. So if at all there will be a scaling over the surface, so the scale cannot go inside the hair follicles usually in other diseases, but here in the DLE, because hair follicle dilatation is going to happen, that is there will be this hair follicle, it is going to become dilated. So because of this, the scale which is present, which is going to be formed, is going to protrude, and it is going to invade the hair follicle, and it will invaginate in this form. If you try to remove, this is the scale, this is the superficial part of the epidermis, and these are the deep parts, this is the hair follicle. If you remove this scale with the help of a tweezer or any instrument, so along with the scale you can see that, so here this will be how the scale will appear. So this is how the scale will appear with all the extensions into the hair, all the scales which are extended into the hair follicle. So this will be the scale. So because the scale is having these tags like structure. So what are tags? Tags are nails which are used to secure the carpets to the floor. So if at all you observe this particular type of scale, then we are going to call it as a tin tag sign. Okay, this is called as a tin tag sign or carpet tag sign. Okay, it is also called cat tongue sign. Why? Because if you have a pet cat, then you will understand why it is called so. Because the cat's tongue is going to have some projections over its dorsal part of the tongue. That is the reason why it is also called cat tongue, tin tag or carpet tag sign. Okay, and in the SLE, now we are observing the SLE. In this, butterfly rash will be there. That is malar rash, which is going to be erythematous, photosensitive rash, which is going to spare the nasolabial folds. And it will be present both on bilaterally, and also the bridge of the nose will be involved. But here you are able to see this nasolabial folds, these are spared. So the butterfly rash will not involve nasolabial folds in the case of systemic lupus erythematosus. And this particular malar rash, it is the acute form of lupus erythematosus. So we have seen DLE is a chronic form. So this malar rash, that is butterfly rash, it is an acute form of this particular lupus erythematosus. And apart from this rash, there is also possibility that discoid lesions can also be seen in these patients, and there is a peculiar type of alopecia happening in systemic lupus erythematosus, which initially will be non-scarring type. That is, only hair loss will be there, but once the disease activity is reduced, there will be again regrowth of hair. But as the disease progresses and it becomes more and more chronic in nature, then ultimately the hairs are going to be lost permanently. That is, there is going to be a scarring type of alopecia or cicatricial alopecia. Okay, so this will happen with time, and there will be also ulcers which will be in the oral cavity and also in the nasal mucosa. So now I want everyone to answer this question. Mechanics hands are seen in. Okay, so very good, friends. Everyone is right. Very good. I am happy. Dermatomyositis is the answer. So I hope all of you also know where Gorton's papules are seen. It is again dermatomyositis. Very good. So now please try to answer this particular question. Balaramakrishna has answered it as dermatomyositis. Yes, Dr. Tharindra, depression can be a presentation of systemic lupus erythematosus because of these chronic inflammation, the patient having all the skin lesions, it is going to cause bothersome effects, because of which there can be presentations of in psychiatric department also. And in fact, we had a patient who had SLE, and she was advised to take the medications, but she was so much depressed due to the disease and its chronicity that we had to refer her to the psychiatry first to treat her depression part. So yes, not only skin and other systems, even psychiatric symptoms can also be presenting complaints of these connective tissue disorders. Yes, you are absolutely right. Yes, so answer here is again dermatomyositis. So in the FMG, maybe the not previously these type of one-liner questions were asked in FMG. Gorton's papules are seen, mechanics hands are seen, but now maybe in this session of December, not very difficult and very lengthy question, but these type of questions can be expected. The patient had erythema with purplish tinge on upper eyelids and erythema over shawl area, significant elevation of serum creatine phosphokinase, CPK levels are there. So what is your diagnosis? And in the image you are able to see this Gorton's sign. So basically I will tell you what is it. You are able to see in this dermatomyositis. So here you are able to see erythema in the metacarpophalangeal joints and the interphalangeal joints. So basically in the knuckles. So all the joint areas you are able to see this erythema. And this dermatomyositis, it has various important signs which are to be remembered. So basically in this dermatomyositis there will be two components, as the name itself suggests. So there will be involvement of the skin. So skin involvement is there, and also there is involvement of the muscle, skeletal system. Muscles are also involved, and that too specifically proximal muscles, but not distal muscles. And there are some named signs we should remember. Gorton's sign. So what is this? There will be a violaceous erythema present over the metacarpophalangeal joints and the interphalangeal joints. So if at all this violaceous type of erythema is there, we have given a name called Gorton's sign in dermatomyositis. And we gave a term called Gorton's papules. So these are all fancy terms. There are many fancy terms associated with dermatomyositis. So Gorton's papules, along with the violaceous erythema, we will see some raised, solid raised lesions called papules. That's all. So here you are able to see this is the Gorton's sign which I have already shown you, and these are the tiny Gorton's papules. And as mentioned by few of the students, very good. So screen is black. I think everyone is able to see. There is some issue, M. Srinivas. So my name only. So yes, you can see also heliotrope rash in dermatomyositis. Okay, that is there will be erythema of the eyelids, erythema, violaceous erythema over the eyelids and over the shawl area. So this area, upper back, it is the area where usually we wear the shawl. That is the reason why it is called shawl sign. So heliotrope rash, shawl sign, Gorton's sign, Gorton's papule. So all of these are seen in dermatomyositis. And one more sign, named sign, in dermatomyositis there is going to be nails which are going to show ragged cuticles. So this is given a name called Summit's sign, SAMITZ, Summit's sign. Okay, and there are important antibodies which you need to remember: anti-Jo1 antibodies and anti-MI2. For FMG purpose, they can maximum ask you only these points, not beyond this: anti-Jo1 and anti-MI2 antibodies. And Scholl sign, I have already told you. There is V sign, that is this part of the body is going to have more possibility of exposure to sun rays, because of which there will be erythema developing over this site, which is called as a V sign. V sign. Okay, it is not V movie, it is V sign. Okay, yes. And one more named sign is Holster sign. So what is this holster? It is the small leather wear which police department usually uses to wear to hide a gun. Okay, so to hide a gun, they are going to use one leather device which is going to be kept on the lateral part of the thigh, where the police department usually keep their guns secured. So this area is also going to show erythema, and it is called as holster sign. Yes, now please try to answer this question in the comments. Salt and pepper skin seen in. This was one of the previous questions. So Gaurav says it is C. Okay. Okay, please read the question carefully, Dr. Sushma Reddy. We are asking salt and pepper skin. So it is not salt and pepper fundus, but it is salt and pepper skin. Okay, I can see most of you have answered it as scleroderma. So very good. The answer is scleroderma. Please remember, there are 3 salt and peppers in dermatology which you should remember. So the first one is, of course, the answer here, systemic sclerosis or scleroderma, where salt and pepper type of skin lesions will be there. Whereas in repigmenting vitiligo, which is another example for salt and pepper type of lesions in vitiligo, this is the repigmenting vitiligo, that is the vitiligo lesions, they are healing. Once the vitiligo lesion, that is the depigmented lesions start to heal, there will be areas of hyperpigmentation and hypodepigmentation which can be seen, which is going to appear just like if you take a salt and pepper when you go to hotels or restaurant. If you add salt and pepper onto your plate, you can see that there will be areas of whitishness because of the salt, and areas of blackishness because of the pepper. So similar appearance of the skin can be seen in these 2 conditions. That is the reason why it is given a name salt and pepper appearance. And in congenital syphilis, the same salt and pepper appearance will be there, but that will be in the fundus. Okay, that can be seen in the fundus. So basically, in the scleroderma, as the name itself suggests, sclerosis is thickening and derma is skin. So there will be thickening of the skin, and it is again divided into localized and systemic types of scleroderma. In the localized types, the most important image based question which can be expected is morphia. It is also called as N-Coupe de Saber. Okay, N-Coupe de Saber. Why is it called so? Because of the involvement of the subcutaneous tissues and atrophy, the skin is over the forehead is going to appear as if someone has taken a sword and stuck over the forehead. Okay, that is the reason why we have given this name N-Coupe de Saber, where saber means sword. So few other areas where we can use this is saber tibia. Okay, so saber means sword. Yes, this scleroderma, it is again divided into limited and diffuse steps. So this is not so much important for FMG purposes. In the systemic sclerosis or scleroderma, the most important pathogenesis again is going to be autoimmunity. So basically, there is autoimmunity on the top of which there is going to be a vasculopathy, and also there will be a fibrosis. And in this vasculopathy, the manifestation clinically will be skin color changes when there is exposure to cold. Here you are able to see this the hands of this particular patient, they are showing this Raynaud's phenomenon where on cold exposure, initially there is going to be a vasoconstriction, because of which the skin is going to appear as white colored, and after this there will be a delayed phase where the pooling of the blood will be seen, because of which there will be bluish discoloration, and after that there will be a sudden vasodilatation once the cold exposure is taken away, because of which there will be reddish discoloration. So this is the order in which the color changes in Raynaud's phenomenon can be seen. Okay, that is white, blue and red. And ultimately, if there is a again re-exposure to the cold, and there is a recurrent exposure to the cold waters or cold temperatures, then because of this Raynaud's phenomenon happening again and again, there will be ultimately development of ulcers, and these ulcers are going to heal as pitted scars. And apart from that, in the systemic sclerosis, there will be another skin manifestations in the form of thickening of the skin will lead to microstomia, that is difficulty in opening of the mouth. And if you try to pinch the skin, you cannot pinch the skin because the skin is excessively thickened. So it is described as hide bound skin. That is, in the animals, if you peel out the skin and if you dry it out, it is going to be very, very thick. So that is how the skin of these patients is going to appear. That is the reason why it is called hide bound skin. And the face will become completely expressionless because all the skin has become thickened, and it is called as mask like faces. So all these were previous year one-liner type of questions. So this is again the salt and pepper appearance in scleroderma, which you are able to see over the upper back. So that's it in this session, friends. So I hope all of you did enjoy it, and if you wish to take a subscription of Unacademy along with the prep ladder, if you want to get best of both the worlds, you can take the iconic subscription. The subscription charges are given here, and you can use my referral code DRMSD to get additional 10% discount on the subscription. And yes, this comprehensive course which is for NEET PG 2022, it is happening now, and we have already finished it, half of the course, and these are the remaining courses. November 29th we are going to have the vesiculobullous disorders topic discussion. This is exclusive for Plus subscribers, and I thank you so much for all your patient listening. So Moin Lala is asking for part 1 revision link. Okay, so I will put the link in this so in the Unacademy Telegram group, there is the link for that. You can get the link there, or if I can put the link, I will drop down the link as a message in this particular video in the comment section. Okay, you can check that, check the comment section. Okay, that's it. If you are having any doubts, you can ask me in the comment section now. Yes, Raksharathi, it is PCR, pallor cyanosis and rubor. So that is also a mnemonic. I remember WBR. Yes, even PCR is also a very good mnemonic to remember the Raynaud's phenomenon and its order. Very good. Okay, bye bye guys. So be careful. So again, tomorrow we are going to discuss the vesiculobullous disorders topic. So do join that session. I will give the link in the Unacademy Telegram group itself. So please be careful and use SMS, that is sanitization, mask and social distancing. And as usual, happy learning. Bye bye.